All right, yeah. So very excited to share this content with you. This is content that's dear to my heart. My grandfather had osteoarthritis in both of his knees, and it massively, massively impacted his quality of life in the later years of his life. And he died in 2009. And since then, there's been so much research that has really changed the way um, the medical community, the science community look at arthritis. And I really wish, honestly, that he had access to the information that I'm going to share with you. I think it could have really changed his actual experience. But I'm really grateful to be here to share with you, and then hopefully you can share this with the people in your life and with your students, etc. So yeah, so a great topic. So I came across this cute little cartoon. And it also sums up how many people feel about their joints. Many people feel that, um, you know, if you're super active, you're going to end up with joint problems. My grandfather was a joiner or carpenter. He spent a lot of time on his knees. He blamed that for his arthritis. We'll look at that. We'll kind of demystify that as we head through the workshop. Yeah, so aims and objectives, we're going to explore the anatomy and physiology of our joints in general. Then we're going to gain a contemporary evidence-based understanding of how osteoarthritis develops. We're going to look at current treatment options. We're going to discuss the current physical activity guidelines for people with osteoarthritis. We're going to explore the research that looks at how yoga can impact osteoarthritis. And then finally, we're going to highlight top tips for teaching yoga to a student with osteoarthritis. So we're going to cover a lot. Enjoy the experience. Don't expect to remember everything that we cover. It's not the way the human brain works, unfortunately. Even if you're joining me live today, make use of the replay. You can watch the replay a couple of times if you want. You're going to take more information each time you watch it. You'll receive a list of the references. So all the studies that I mention, you'll get a list of those as a PDF. You'll be able to download a PDF of this presentation. I'm going to encourage you afterwards to take time to reflect and write down 5 things that you'd really like to take away with you that are maybe going to impact your practice, your teaching, your life in general. And by sharing those with someone else in your life, you've got a really great chance of retaining that information. So it's 5 things I'd like you to take away. You do not have to remember everything we talk about today. Enjoy the experience, enjoy learning. Little disclaimer, I have a medical background, but this is an educational workshop aimed at updating yoga teachers on the latest information about arthritis. So it does not equate to medical advice, the information that I share. You must consult a healthcare professional before implementing any of the activities shared in the workshop. It just keeps us all protected. Yeah, so anytime I'm in a teaching environment, I talk about lenses that can get in the way of us receiving information. And when we're able to push those lenses out of the way, we're actually able to learn more. So the first lens is called confirmation bias. And essentially, it's when we're learning about a topic, we tend to focus in on the information that confirms our pre-existing belief. And by doing so, we ignore other information that actually might challenge that. And then we lose the opportunity to grow and develop. Okay. So even if a topic today feels familiar, just come with a really open mind. Cognitive dissonance is when we choose to reject information that does not confirm our pre-existing belief. So if you feel yourself cringe a little bit or feel uncomfortable, see if you can just breathe into that, relax, take in the information. I'm not trying to purposefully, push your buttons and trigger you. I'm coming at this from a very much evidence-based perspective. These aren't really my opinions. This is based in like the latest science. Yeah, so when we're aware of these lenses, we can push them out of the way and we can, learn more information. So another cartoon that I came across about confirmation bias. A lot of this in the world at the moment. All right, so a couple of questions for you to consider. You don't have to answer them, but just consider these. Do you currently believe that osteoarthritis is caused primarily by wear and tear? Is this a belief that you have? Can yoga cause osteoarthritis? There's some talk about this out there. Should people with arthritis load their joints less? And can we make choices that can reduce our risk of developing arthritis in the future? Things to consider. So these are things that we will look at as we head through. We're going to kick off by looking at our joints. We're going to get to know the anatomy and physiology of our joints. What is a joint? It's the junction between two or more adjacent bones. Depending on the type of joint, the different bones may or may not move in relationship to one another. And it's also called an articulation. It's another term for joint, like a fancier term. Loads of different types of joints. A fibrous joint is essentially an immovable joint. So we used to have separate bones in our skull. We had the fontanelles as babies, the soft parts. Then we have one skull as an adult. All the bones fuse. So there are examples of fibrous joints that separated originally the separate parts. Cartilaginous joints are slightly movable. So your symphysis pubis, which is at the very front of your pelvis, just a couple of inches below your belly button, that is a slightly movable joint. The main joint we're going to focus on, the main type of joint, is a synovial joint, a freely movable joint. Think of your hip joint, your knee joint, your elbow joint. Yeah, so this is what we're going to spend most of the time focusing on. So these are considered the main functional joints of the body. And they're characterized by the presence of a joint cavity. So basically like a little space here between the bones. And their primary purpose is to prevent friction between articulating bones. It's the primary function of a joint. And also obviously allow for movement at the same time. Yeah, so they're surrounded by an articular capsule. So you'll see this here in the diagram that helps to seal the joint. This is basically, yeah, a fibrous connective tissue attached to each participating bone. And then inside of that capsule, we have the synovial membrane here in orange. Okay. So this, or sometimes called the synovium, and this secretes synovial fluid. Okay, we'll get to know a bit more about that in a second. And then very important, just sorry to go back for a second so you can see this in the diagram. We're now going to focus on this substance here, which is called the articular or sometimes the hyaline cartilage. Let's get to know the cartilage. So hyaline means glassy or translucent. It's a connective tissue. It's continuous with the synovial membrane, and it covers the entire part of the bone that is articulating. So it's made up of highly specialized structure. So this provides the joints with mechanical features such as load-bearing capability, low friction quality, and smooth movement. Okay, this cartilage is one of the smoothest substance known to man. Pretty amazing. Okay, the surface is smooth to the finger like that of a billiard ball. Okay, but actually, when you look at very detailed images, it's actually more irregular, a bit like a golf ball, but that's not what it would feel like if you were able to touch it. The areas of the cartilage nearest to the bone are impregnated with calcium salts. Okay, and this creates a barrier to the passage of oxygen and nutrients to the cartilage from the bone. Okay. So how do we get around that? Well, this also means that cartilage does not have a direct blood supply, and it gets its nourishment from the synovial fluid. Okay, not from direct blood supply. So that's an interesting quality. The articular cartilage is comprised of what are called chondrocytes. Okay, these are cells that produce collagen and extracellular matrix. In healthy cartilage, water, collagen, and a particular substance called protoglycan together make up about 90 to 95% of the total content of the cartilage. And due to the avascular nature, so the fact that it doesn't have direct blood supply, damaged cartilage has a finite capability for healing and regeneration. So it doesn't mean that there's no capability, but it is finite. It's limited. So that's important to know. But like other tissues of the body, our articular cartilage responds to the demands placed upon it. Okay, so it's important to know. So interestingly, when astronauts return from space, their cartilage is thinner than it was previous because they've not been exposed to gravity. So this is a great example. But then within a few weeks of regular activity back on Earth, the cartilage returns to its normal thickness. Yeah, so cartilage adapts. And then a little bit about synovial fluid. So it's essentially filtered blood plasma, and it has a top characteristic called it's fixotrophic. Okay, it means it's both viscous and elastic. And this is due to the presence of hyaluronic acid. So this is a substance that is now found in a lot of beauty products because it holds moisture in. So a lot of moisturizers have hyaluronic acid. Viscosity, the stickiness of it, decreases with an increase in the speed of the fluid when we're in motion. So this allows the joint to actually move more. And elasticity increases with an increase in the speed of the fluid. So it's better able to support the joint. So that's pretty cool. And it provides both nutrition, as we've talked about, and lubrication, helps prevent friction. All right, so that's a little bit about the anatomy and physiology of the joint in general. Let's dive into arthritis. So it's an umbrella term for over 100 conditions that affect our joints, our tendons, our ligaments, our bones, and our muscles. Okay. Arthritis provides the second most common cause of disability worldwide. So this is back in 2013. It's edging towards number one. Since then, the disability burden is also rapidly escalating. So it's a big, big, big problem worldwide. Approximately 23% of US adults report having a diagnosis of arthritis, so nearly 1 in 4. That's huge. Of these, 44% complain of arthritis-related physical activity limitations. Wow, that's big. And this is expected to increase to an estimated 78 million Americans by 2024. And that's the similar trend globally. Okay, so it's a huge issue. There are lots of different types of arthritis, as we mentioned. The two most common are osteoarthritis and rheumatoid arthritis. We're going to actually focus today on osteoarthritis. So let's dive into that. All right, so osteoarthritis, it's a progressive local joint disease affecting one or more of the synovial joints in the body that we just looked at. Most commonly affects the hands, the knees, the hips, and the spine. And it's characterized as primary if there is the absence of an underlying cause, and it's secondary if there is a clear underlying cause or significant triggering event such as prior trauma or a fracture. Okay, this is a big one, so take a moment to take this in. The crude bone-on-bone or wear and tear model is being challenged and completely redefined. Okay, rather than a degenerative condition caused by movement, loading, and wear and tear, OA is now believed to be a multifactorial disorder. So there's many factors at play in which low-grade, persistent, systemic inflammation has a central role. So low-grade inflammation that is throughout the body is happening to show up in certain joints for certain people. That's what we're realizing, okay? So it's way more complicated than we first imagined, or we imagined decades ago. And inflammation plays a key central role. Okay, so very important to recognize this. The process of OA is more of a molecular than a mechanical one. So we are not mechanical structures like a car. We don't just break down over time. Yeah, we are biomechanical. So that's a very different process. Okay, it's a much more complex disease, as we've mentioned. And during OA progression, the entire synovial joint, including the cartilage, the subchondral bone, so the bone line beneath the cartilage, the synovium, are all involved in the inflammation process. Okay. The most common symptom of OA is joint pain, which tends to worsen with activity, especially following a period of rest, even overnight sleeping. It can be painful in the morning. OA can cause morning stiffness, often referred to as the gelling phenomenon, and it usually lasts for less than 30 minutes, and then the joint will start to, move a little more. People with OA may also report joint locking or joint instability, something that like your knee kind of gives way. These symptoms result in loss of function, with people limiting their activities of daily living because of pain and stiffness. So we really don't want that to happen. We want people to be as active as possible. So let's look at some risk factors. So being overweight or having obesity is a risk factor, but we realize it's more nuanced than this. So we're going to come back to this. Having a history of joint injury or surgery is a risk factor. There's a genetic predisposition. So if you have OA in your family, you have a higher risk of having it. Your age, it does increase with age. Your gender, we'll look at this a little bit. Yeah, so lots of different risk factors. So body weight and some structural joint changes are associated with knee osteoarthritis and sometimes pain, okay? And in addition to the increased biomechanical loading on the knee joint, obesity is thought to contribute to low-grade systemic inflammation through the secretion of what's called adipose tissue-derived cytokines, okay? We've said it's more nuanced. Some people with OA are slender, so weight isn't always a huge factor here. You can have, have low weight and have arthritis. Arthritis is also common in the hands. We don't walk on our hands. The hands aren't load bearing. Okay, so it's more complicated than this. Interestingly, weight doesn't necessarily have to change to decrease pain. So you don't have to lose weight in order for your pain to improve. It's the physical activity that's most important. So losing weight is often helpful, but it's not entirely necessary. Exercise alone can reduce pain. So as long as you're exercising, even if you're not losing weight, this can help to manage your symptoms. Okay. And another interesting study told us that the prevalence of osteoarthritis doubled in the 20th century, and this was completely independent of age and weight. Okay. So weight can play a factor, but it's nuanced. Another risk factor. So there's a study that looked at quadricep weakness. And the quadriceps, the main muscles at the front of the thigh, the knee extensors. This weakness is a risk factor for the development of knee osteoarthritis. Again, another study looking at thigh strength and found that it's associated with a decreased risk of arthritis progression after meniscus surgery. Okay, so the strength of our muscles, how physically active we are, plays a big role here. And then this is just a little diagram. It's just showing that things are complicated. There's a lot of factors at play. Yes, there are body measurements like our BMI, but there's also all these inflammatory markers, things like hormones, going on. So it's a complicated thing. It's way more complicated than just thinking of mechanical wear and tear. Okay, how do we currently diagnose osteoarthritis? So in OA joints, the subchondral bone undergoes remarkable remodeling in both its composition and its structure. Okay, this includes micro-architectural damage, bone marrow lesions, and the formation of bone cysts. Okay, and because of this, this means that currently X-rays are often used to confirm the diagnosis of osteoarthritis. In the diagram here, one side is normal, one side shows changes through osteoarthritis. So there are three signs that a doctor will look at or a clinician will look at. They'll look for joint space narrowing. They'll look for the formation of bony spurs. They're called osteophytes. And they'll look for joint destruction. Okay? It's more complicated than this. Let's take a look. So clinicians are now beginning to think of these classic X-ray changes that we've just discussed as normal age-related structural changes. Okay, this is totally changing the way we look at things. Okay, you can have these structural changes, and that only increases your chance of experiencing joint pain. It does not guarantee that you're going to have joint pain. Okay. When people with pain have a scan and normal age-related changes are reported as either degeneration or abnormalities, those people recover more slowly regardless of the nature or cause of their original problem, compared to people that are set or that are told these are normal age-related changes. Okay, so language is super, super important. The way language is given to us by the medical profession is super important. It affects our experience. Between 19 and 40% of people with structural changes on an X-ray that would typically get them diagnosed with OA do not have joint pain. How interesting, okay? If someone with OA does experience pain, these structural changes are only one factor in the bigger picture. So it has to be taken with a slight pinch of salt. Okay. Someone can have structural changes on an X-ray and their pain can decrease over time while their X-ray looks the same. Okay. People with OA still have synovial fluid in the affected joints, even though they might have these structural changes that we've talked about. Things don't have to get worse. This is really important. My grandfather really felt that he was just on a slippery slope. It was going to get worse as each month progressed. Things don't have to get worse. Knee osteoarthritis is characterized by persistent symptoms, okay, rather than this inevitability that things are going to worsen over time, okay? Even when X-rays show more joint changes, it tends to be persistent, but it doesn't mean it's always going to get worse, okay? There was a study here that found that the involvement of inflammatory components, such as things called cytokines, chemokines, and other inflammatory mediators that are produced by the synovium and the chondrocytes, can be easily measured in the synovial fluid of OA patients and is now well recognized as means of diagnosis. So this is helping to improve the way we diagnose things. It's not just X-ray changes anymore. We can also use these blood markers to help diagnose. Okay, so Britney Spears is here with a quick self-test. Britney and I are separated by 1 day. She's 1 day older than me, so I have this affinity to her. So think of the question or the answer out loud, or you can share in the chat, however you like. So cartilage is largely dependent upon the what for its nourishment. So what is the component of the synovial joint that helps provide nourishment to the cartilage? Fantastic. Yeah, great. Well done. Yeah, we've got a few correct answers here. Brilliant. It's the synovial fluid. Well done. Very good. Question 2, true or false? When astronauts return from space, their cartilage is thinner because they have not been exposed to gravity. Is that true or is that a complete myth? Yeah, well done. That is true. Cartilage is adaptable. Okay. Rather than a degenerative condition caused by movement, loading, and wear and tear, osteoarthritis is now believed to be a multifactorial disorder in which low-grade chronic blank blank has a central role. So what are the blank spaces here? Yeah, fantastic. So it's a specific type of inflammation, which is systemic. It means inflammation that's throughout the body, happens to show up in certain joints for certain people. Yeah, very interesting. The great thing is there are ways we can tackle inflammation. So this is really helpful to know. True or false, in osteoarthritis, body weight has to decrease in order to decrease pain. Exercise alone can't reduce pain. Is that true or false? Yeah, well done. That is false. Body weight does not have to increase. It's the physical activity that is the most important thing. And we'll look at this a little later. All right, another quick question. Thigh strength is associated with blank risk of arthritis progression after meniscus surgery. What does this do to the risk? Yeah, fantastic. Yeah, well done. Yeah, decreased, reduced risk. Fantastic. When people have pain and when people with pain have a scan and normal age-related changes are reported as degeneration or abnormalities, those people recover more blank, regardless of the nature or cause of their original problem. Yeah. Language is super, super powerful. Our language, the language we use about ourselves or the language that people use to talk to us has a massive impact on our experience. So it slows, recover more slowly. True or false, someone with OA can have structural changes on an X-ray and their pain can decrease over time while their X-ray looks the same. What do we think? Yeah, yeah, absolutely. Things don't have to get worse. That is true. Oh, no, I thought there was one more question. There isn't. Okay, well done. Let's look at pain in general before we dive into more osteoarthritis topics. So, pain is very complicated. Okay, pain and tissue damage do not always correlate. In the past, if someone had shoulder pain, we used to think, okay, there's an issue with the tissues of the shoulder. We're recognizing there's not always a correlation. Okay, the longer you have pain in a certain part of the body, the weaker the correlation with tissue damage, the less chance that it's just to do with the tissues. Okay, the more chance that it's got something to do with something else that's going on in your life. Okay, very fascinating. Okay. It is very possible to have tissue damage without experiencing pain. And it's also possible to experience pain when there is no apparent tissue damage. Okay. Nearly every condition we assume to be a sign of dysfunction. So think of all the talk about poor posture. Oh, this tight muscle causes this, weakness here or degeneration causes this. All these things can exist in people without the presence of pain. You can have terrible, terrible posture. You can have tightness, weakness, degeneration, and you can have no pain. Okay, so it's very complicated. Inflammation has a big effect on danger detectors, making them more sensitive. Okay? Danger messages are not pain, they are simply nerve impulses. So, this is a big one. Our brain doesn't detect pain, it makes pain. So just take that in for a second. If you were to put your hand on a hot stove, you don't feel pain from the stove. A impulse is sent to your brain and your brain produces pain so that you pull your hand away and don't like get a first degree burn. Okay? So danger messages are not pain, they're simply nerve impulses. Our brain doesn't detect pain, it makes pain. Okay? This is a big one. Persistent pain is often correlated with depression, with fear, with rumination, and worries about injury. Okay. Yeah, Laura, it is really, really fascinating. Laura, I fully agree with you. Pain can be thought of as all of life's stressors. So think of the physical stresses in your life, the social stresses, the psychological stresses, the spiritual stresses, exceeding our perceived ability to withstand or adapt to these. Okay. To optimize outcomes, the identification and treatment of associated psychosocial issues is of paramount importance. The biopsychosocial model is a way of understanding how suffering, disease, and illness are affected by multiple levels of organization from the societal to the molecular. And this is an example of a biopsychosocial model. All these factors could play a role in your experience of pain. It's way, way more than just tissue damage. It could be your family relationships, your socioeconomic status, your disability or ability levels, your coping and social skills, you know? Super interesting. What causes pain in knee osteoarthritis specifically? Well, there are no nerve endings in the bone itself. Okay, that's interesting, isn't it? So if two bones are rubbing together and all else is well, that won't hurt. You won't get pain from that. Okay. The cartilage in the knee also does not have nerve endings in it. So even cartilage rubbing, that's not going to initiate pain in itself. Okay, so thinning cartilage won't hurt. What does cause pain? The pain's going to come from three areas potentially. It's going to come from the periosteum. That is the connective tissue that covers the bone surface. It's like a type of fascia. So you can get pain coming from the periosteum. You can get synovitis, so inflammation of the synovial membrane. That can cause pain. Okay. And then you can get edema or fluid building up in the bone marrow within the bones of the knee that can cause pain. So it's not bone rubbing against bone, but it's coming from these three other areas. Okay. Again, inflammation is playing a key role here in generating the pain. Okay. Not everyone with OA will have, synovitis, bone marrow edema, or pain due to the periosteum. Okay. If someone does have pain because of those issues, it will often calm down after a few weeks or months. So it's not, it's not going to always get worse. It can come in peaks and troughs. For the majority of people, the status of their knee will return to baseline once again, and then you'll maybe get a flare up. So it's dynamic. Okay. Disease severity does not correspond to the level of reported symptoms in OA patients. Okay, some people have structural destruction. That's a mouthful. In their cartilage while they are asymptomatic. So we've talked about similar themes before. And then joint stiffness is like pain. It can remain even when there is no structural damage or swelling of the joints. It's a protective feeling being produced by the brain. That's what stiffness is. It's a feeling. Okay. Like pain, stiffness changes. And over time, this feeling can improve for people. Joint stiffness can improve. Yeah, how interesting. It's all to do with the nervous system. Okay. This was an interesting study. It found that pleasant whooshing noises, think of like white noise, made people's joints feel less stiff. Maybe we should have whooshing noises in a yoga class. Unpleasant creaking noises, think of it like a rusty door creaking, made their joints feel more stiff. Yeah. Even though the actual stiffness of their joints didn't change, it was a perception. Super, super fascinating. Why do joints make noises? Okay, this is a big one, isn't it? There's a lot of studies about this. People often hold negative beliefs about the noises that their joints make, and in turn, this may negatively affect their behavior. We really don't want that to happen. There is a common belief that noises denote degeneration and premature aging. Okay, joint noises make people feel old, and at times this leads to them being less active. We do not want the world being less active. We want people to be more active. Okay. Joint noises are extremely common. They're referred to as crepitus in the medical world. Clicks are most likely due to muscles and tendons moving over each other or over bones. Little pops are most likely air bubbles forming in the synovial fluid. And any grinding or grating noises, sometimes you can feel that when you turn your head, they can be quite alarming, but are also usually harmless. Okay. Crepitus is often present in the complete absence of any joint issue. A helpful guide is if that you're not experiencing pain or any other symptoms along with the joint noises, then it's nothing to worry about. Okay. If pain or other symptoms accompany the joint noises, then advice from a medical professional should be sought. Okay. So that's interesting. So let's look at OA treatment and recovery. So optimal treatment features a multidisciplinary approach. This includes drug treatment, education, like these kind of webinars, physical therapy, occupational therapy, and exercise. Okay. Three critical ingredients for OA recovery include increasing your knowledge about your body, increasing activity, and decreasing inflammation. These are the three benchmarks. Okay. Together, they facilitate the enormous potential for change within everyone. The irresistible force for change is called bioplasticity. Bioplasticity. You might have heard of neuroplasticity. This is talking about muscles, bones, connective tissue, bioplasticity. Okay, so increasing activity helps you to improve your knowledge about your body and improves inflammation. Increasing knowledge helps you to improve inflammation and your activity levels. It all feeds into one another. Okay. Decreasing inflammation helps you to improve your knowledge and activity. Okay. 10 top tips for reducing inflammation in your body. Slowly increase your activity levels bit by bit. Eat more anti-inflammatory foods. Basically, follow a Mediterranean diet. Avoid highly processed foods and refined sugar where possible. Okay, alcohol is also inflammatory. Seek knowledge about your physiology, like taking webinars like this. Okay, challenge your perceptions about your well-being. If you're convinced that you're going to get worse over time, you're going to get worse over time. Challenge that. Challenge those beliefs. Laugh regularly. Okay, it's been shown to help. Maintain good social support, very, very important. Prioritize sleep and rest, completely undervalued. Sleep is so, so, so important. Rest is so important. Interact with nature as much as you can. Reduce alcohol consumption and stop smoking. And finally, create a stressful event response plan. So if you know that a certain family event always triggers you and you get stressed, create a plan around that about how you're going to cope with it. Okay, if I start to feel myself get stressed, I'm going to nip out. I'm going to leave the room. I'm going to hide myself in the bathroom for 5 minutes. I'm going to do a breathing practice and then I'm going to enter the room again. Creating plans for events that you know are stressful can help lower inflammation over time. Okay, our thoughts and feelings can increase inflammation, and inflammation can affect our thoughts and feelings. It's this vicious cycle. Okay, when what someone says about their joints and how they feel about their joints can influence how they feel, and how much inflammation there is. Okay, so the language we use to talk about our body is super, super important. Let's now look at pharmaceutical treatment. Treatment for OA has shifted from the supportive to the preventative or regenerative, aiming at decelerating or reversing the progress of cartilage degeneration. So that's very exciting. There's a type of drug being developed that's called disease-modifying osteoarthritis drugs. So that's very, very exciting. Regeneration of cartilage still remains one of the main challenges, particularly in an actively inflammatory environment. So while this has been, discovered by science, we're going to try to keep inflammation as low as possible. Okay. I'm going to actually flick through this quickly just because I'm aware of time and there's just so much other stuff that I want to get onto. Let's look at the physical activity guidelines based on a lot of information, a lot of research we have. Although pain and functional limitations can present challenges to individuals with arthritis in terms of performing physical activity, regular exercise is essential for managing osteoarthritis. Individuals with arthritis are more likely to have muscle wasting and excess body fat than same age and sex healthy individuals. So another reason why exercise is so important. Thus, regular exercise plays an important role in weight control and achieving a healthy body composition, both through the tissue building and fat burning effects of the exercise itself and via the anti-inflammatory effects of regular physical activity. So your nervous system is amazing at conserving energy. When you are physically active on a regular basis, your nervous system recognizes that and it starts to basically reserve energy to allow you to be physically active. And the best way that it can reserve energy is by lowering inflammation in your body. Like, how amazing. Aerobic, strengthening, aquatic, Tai Chi exercises are beneficial for improving pain and function in people with OA. So really, really amazing. Just going to check in on the question. Yeah, Dan says, wow. Yeah, really, really remarkable stuff. Regular exercise provides numerous additional benefits to individuals with arthritis. It minimizes functional decline, improves functional capacity, reduces your fall risk. This is where yoga plays a big, big role, helping to reduce falls, attenuating pain and joint stiffness, and reducing other comorbidities. So regular exercise, just so, so important. Being active doesn't wear out your joints. I'm going to say it one more time. Being active doesn't wear out your joints. Okay, moderate exercise may be a good treatment not only to improve joint symptoms and function, but also to improve the knee cartilage glycosaminoglycan content in patients at high risk of developing OA. Like, it's mind blowing. Okay, that exercise is going to actually help to prevent OA. Okay, running does not increase symptoms or structural progression in people with knee osteoarthritis, unless you're like an elite marathon runner, everything in moderation, but running in general does not increase symptoms or destruction of the joints. Okay, complete myth. Surgery can play a role. When joint damage and loss of mobility are severe and restoration of a reasonable level of function and control of pain is no longer achievable by pharmacological and conservative management, total joint replacement and other surgeries are therapeutic options, okay? But there's more to this because there was an amazing study done in 2015. Okay, it basically looked at a 12-week non-surgical knee osteoarthritis management program, and it found that this can prevent total knee replacement surgery in people deemed candidates for this in up to 74% of people with knee osteoarthritis. Huge. Let's dive into it for a second, okay? Really amazing. So they took 100 patients with moderate to severe osteoarthritis in the knee. They were randomly assigned to one of two groups. They either underwent a total knee replacement and then had 12 weeks of non-surgical treatment afterwards, or they received 12 weeks of non-surgical treatment, okay, without having the surgery. Okay. The non-surgical treatment was delivered by physiotherapists and dietitians and consisted of exercise, education, dietary advice, use of insoles, and pain medication. Okay. The primary outcome was the change from baseline to 12 months. Did I say 12 weeks here? Yeah, it's a 12-week program, but we looked at this over a year. Um, in the main score for basically pain, symptoms, activities of daily living, quality of life. So it's a really well done study. Okay, so the non-surgical group did basically what's called neuromuscular exercise training. It's actually pretty basic when we look at it. This was done for an hour, group-based supervised sessions twice a week for 12 weeks. So not a lot. That's only 24 sessions. Let's take a look at what they did. So, and then after the 12-week program, the patients underwent an 8-week transition period during which the exercise program was performed increasingly at home. So that's where we get the year-long kind of progression. Yeah, and they had support by a physical therapist, like remote support. Okay, so this is what it looked like. 10-minute warm up on a bike, then a circuit program that included core stability, postural function, postural orientation, and lower extremity muscle strength. Okay, functional exercises. It's really not, reinventing the wheel here. Pelvic lifts, sit-ups using like a big exercise ball, different sliding the back foot out, slide into the side, lunges, very typical exercises. Different exercises for knee flexors, hip adductors, knee extensors. Again, nothing, outside the box here. Stepping and standing up from seated. Pretty standard. Okay, so I'm just going to flick through this quickly because I'm aware of time and I don't want to run over too much. Yeah. So, and these were progressed, as people were ready to go on to like another variation. And then they also had education. Think of this session. They had dietary advice that we've mentioned. Yeah. So let's look at the results. So only 26% of the non-surgical group had a total knee replacement in the following year. This suggests that up to 74% of candidates can delay the need for surgery. There was another study that followed up with this a couple of years later, and still 68% of the non-surgical group had avoided total knee replacement after 2 years. So surgery can be avoided. This is a big operation. There's risk that comes with it. And if we can avoid it, fantastic. Okay. Here's the thing. There is a lot of evidence that says that people with arthritis commonly do not receive care that aligns with quality indicators. In a meta-analysis involving over 16,000 patients, only 39% received a referral or recommendation to exercise. Shocking, 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 shocking. In a study involving nearly 500 people with knee osteoarthritis, only 54% had ever tried a muscle strengthening exercise. Crazy. And they probably went ahead and had surgery. So surgery isn't always completely avoidable, but we can lower the number of surgeries happening by a big margin. So another quick self-test. True or false? Pain and tissue damage always correlate. And the longer a person experiences pain, the stronger the correlation. What do we think? Yeah, that is very, very much false. Well done. True or false? There are no nerve endings within bone and within cartilage. Yeah, fantastic. That is true. Very, very interesting stuff. Some people have structural damage to their cartilage while remaining asymptomatic. So they have no symptoms, even though they have structural damage. Is that true or false? Absolutely true. So we have to take X-ray findings with a pinch of salt. Joint noises make people feel old, and at times this leads them to be less what? Active. And that's not something we want to continue happening. So yeah, we need to re-educate people on joint noises. True or false? Knee stiffness can remain even when there is no damage or swelling in the joints. Absolutely, because it's a perception, something we're perceiving. Really interesting. Can you define the concept of bioplasticity in your own words? Have a think about that. We're going to skip on just for time, but have a think about how would you define bioplasticity? True or false, being active doesn't wear out your joints. This is a big one. What do we think? Yeah, absolutely true. Please be as active as you want to be. Don't let any fear get in the way. Running increases symptoms and structural progression in people with knee osteoarthritis. What do we think? Absolutely not. Absolutely false. There's a lot of high quality evidence that tells us the opposite. Yeah, not in moderation. Exactly, Nancy. Well done. Beautiful. Okay, I'm aware that I'm going really quickly, but bear with me. Okay, so the American College of Sports Medicine, a fantastic organization. They talk about exercise prescription. So a major barrier to individuals with arthritis starting an exercise program is the belief that exercise, particularly weight-bearing exercise, will exacerbate joint damage and symptoms such as pain and fatigue. Okay. The fear is prevalent not only amongst individuals with arthritis, but also amongst some physicians and health professionals. Okay. Thus, individuals with arthritis need to be reassured that exercise is not only safe, but also widely and consistently reported to reduce pain, fatigue, inflammation, and disease activity. Exercise is the key. Okay. People with arthritis, particularly those with pain and those who are deconditioned, so not used to exercising, should gradually progress over time. Okay. Slow and steady. I'm going to skip through that. Yeah. So start slow, start low, go slow. Initiate an exercise at light to moderate, and then increasing over time as people can tolerate it. Break up sedentary behavior by encouraging movement throughout the day. That's very beneficial. So it's not just like do this big yoga class once or twice a week. It's like if you can do 15 minutes of yoga, once or twice a day, that's where the magic comes in. Yeah, so little bouts. Flexibility training is important. So yoga is super helpful. Active range of movement can shorten the episodes of morning stiffness. So that's a big one. Some things to consider. Balance training is very, very important. So this is again was where yoga plays a really important role. I just saw there's a question there. Okay, just to see it on the track. Does rubbing castor oil on hurting knee help to reduce inflammation, hence pain? I'm not entirely sure. I would say if it helps an individual, by all means. I don't know if there's a lot of research on it, but if it helps someone, keep doing it. So yoga is amazing for balance training. as most of us know. I've definitely noticed my balance improve over the time. There's a little bit of research that looks at this. Adequate warm up and cool down is important for arthritis patients. Um, yeah, again, I'm going to just, yeah, so avoid strenuous exercise during an acute flare-up or arthritis. However, it's still appropriate to have light activity. So, lying on the sofa all day or being in bed, it's just not recommended. You still need to do light activities. Strenuous exercise might need to be paused for a day or two, but stay active. Yeah, apologies for skipping, through this, but I just want to get to the juicier parts. You'll get the slide so you can revisit this. And I'm going to sum all of this up in a second anyway. Um, yeah, encourage individuals with arthritis to be active during the time of day when pain is typically least severe. That can be a good one. And then incorporating functional exercises like, getting up to stand from a chair, very, very helpful. I'm going to share with you these wonderful infographics, when you get the slides and the references. Just super helpful, again, from the American College of Sports Medicine. Lots of very helpful tips in general. And then they also go into like how to approach aerobic activity, how to approach strength training if you have arthritis, flexibility training, things like that. It's a really nice little infographic that will be helpful for you or for anyone in your life that has arthritis. Activity is all about the Goldilocks principle. So it takes time to find the sweet zone. Okay. It's the amount of activity that is not too small, but also not too big. You're trying to find the just right. And that will also change day to day, week by week. It'll change through the seasons. So a little bit of research that's looked at yoga for osteoarthritis. This is a big meta-analysis. So it includes like over 1,600 patients. This is more than just arthritis, but also low back pain and things like that. Um, Evidence suggests that yoga is an acceptable and safe intervention for arthritis, which may result in clinically relevant improvements in pain and functional outcomes associated with a large range of musculoskeletal conditions. So that's nice to know. That we need a little bit more better quality research, just to hone in on the details. There was this really nice study done 10 years ago, a randomized controlled trial using an integral yoga approach for people with arthritis. Um, they came to class twice a week for 8 weeks, and they had supervision by a yoga therapist, and then they were also asked to practice once a week. Very, very traditional practice. Again, nothing outside the box here. I'll show you that in a second. I'm just going to sum this up. Very, very simple. Warm up, some upper body stretches, inverted plank, cat cow, downward dog, some sun salutations, some standing asanas. Very, very typical yoga class. Um, the preliminary evidence suggests that yoga may help sedentary individuals with arthritis safely increase physical activity and improve physical and psychological health and health-related quality of life with no adverse outcomes. Yoga is not going to wear your joints. My goodness, that's terrible information that's still out there. And then, yeah, another systematic review. This is the gold standard of medical evidence. Over 600 clients indicate that yoga may be effective for improving pain, function, and stiffness in individuals with osteoarthritis. Yeah, and again, just we need better quality research ultimately. But yeah, but that's all good news. So some general advice for yoga teachers teaching people with arthritis. Adopt a positive, encouraging approach. Notice how you respond when students tell you about their health. Just be like, thank you so much for telling me that. How do you think I can support you today? Rather than be like, oh my God, that sounds terrible. Don't feed into anything. Remind students that they are not wearing their joints out by being active. Okay. I love terms like bend and mend, motion is lotion, movement is medicine. Yeah. Remind students that joint noises are normal. Okay. Just going to check in with you now. Nancy says, would you say that yoga alone is sufficient or should be complemented? I would say be as active as you can. Yoga is a great stepping stone. Often people need a little more than that. Um, Jamie says, have you known of a Liz fracture? I would say, Jamie, follow up with me directly. I'm going to share my email address with you. If you follow up with me by email, I think I'll be in a better position to offer some support for that. Um, New students with arthritis should ideally talk to their doctor. Are there any limitations or restrictions their doctor wants them to observe? Getting specific recommendations or concerns in writing can be pretty helpful. Become confident modifying poses. Do this in your own practice. Play around with poses. Get really confident using props. Practice variations. I've talked about that. So you can feel the variations in your own body, and then it's easier to teach them to other people. And don't just focus your attention on the affected joints. Focus on all the parts of the person's body that are not causing them aggravation. Okay. Any thoughts on particular poses that might be contraindicated with knee? I would say just expand your toolbox, have props at your disposal, and base it on a person's comfort level. So if someone is uncomfortable, play around with props and find a version that is going to be more comfortable. There isn't like a blanket statement that's going to work for everyone. It's going to be quite individual. Linda says, are there any suggestions for individuals to practice yoga having a double knee replacement? My grandfather had a double knee replacement. Not specifically, Linda. There's nothing that pops to mind. Again, it's just getting super confident with pose variations and having the props at mind and just playing around with things. How can we support? Can we put a rolled up blanket under the knees? Can we sit up on a bolster? Does that feel more supportive for the knees? Just playing around with that. Um, Pamela said, fantastic. Yes, I do know Jivana. He's amazing. Um, yeah, no problem. Great. Yeah. All right. This is a really great book that I've come across. Hopefully you can see it. Okay, it's called Epiphany, A Modern Approach to Osteoarthritis. There's some great little exercises in there. Very basic stuff. Again, none of it's changing, like trying to reinvent the wheel. But that book is really great. I'm going to give you a link to it. I found that really, really helpful. There's some really nice, simple exercises in there that you can, definitely approach. Honestly, it's for me, the big part is the space that you hold for people. Just be super encouraging. Very quickly, I know that we've reached the hour. I'm going to try to wrap this up. I don't want to steal your time. Yoga after a hip replacement, it's going to depend on the person, the surgical method used, and the type of implant. So get information from them, find out what they're being told from their physical therapist. The aim is really to prevent a recent hip replacement from dislocating while you build strength and flexibility. Okay. Dislocations are rare. They're usually very patient specific, but there's some general recommendations. Okay. If the hip replacement is from the posterior approach, initially you're probably going to avoid poses such as downward dog, deep forward folds, and seated twists or pigeon. Um, when the anterior hip, while the anterior hip replacement has a much lower risk of dislocation, it's often recommended that patients initially avoid poses that place their hip in a lot of extension. So think of warrior one, warrior two, crescent lunge. But get advice. Get the student to get advice from their physical therapist about what they can do, what they can't do. It's going to be very like patient specific. But these are some general pieces of advice. A new hip also needs time and patience to fully, get back to its like mobile range. That timeline is going to differ for different people. Yeah, it's a very, very personal. Yoga after a knee replacement, how much someone is able to comfortably move their knee during physical therapy is a good guide for what yoga poses are appropriate to try. What is their current range of movement in their knee? Can they get up and down from the floor? Things like that. Chair yoga is probably going to be very, very helpful. Some students are not comfortable kneeling, so blankets, padding, even knee pads can be helpful. Be mindful not to hyperextend the knees while they're rehabilitating. Consciously keep a slight bend in the knee, just enough to keep it unlocked in standing poses. That's a good piece of advice. Um, yeah, so this is an example of I share a lot of this on social media, modifying pigeon. You can do pigeon on the back, you can do it in a chair, lots of different ways. The more comfortable you get with these variations, the more tools you have at your disposal when you have people coming to class. Okay, final self-test with Brittany. True or false? There is clear evidence that supports avoiding or discouraging high impact activities such as running, stair climbing, and those with stop and go actions in individuals with arthritis. What do you think based on what we've talked about? Do you think there's clear evidence to avoid these things? There isn't. There isn't. We didn't look at that specifically, but that's the tone that we were definitely approaching now. There isn't clear evidence. Um, Research evidence indicates that resistance training reduces chronic pain through systemic changes. What do we think? Yeah, absolutely. Physical activity is the key here. True or false? A small amount of discomfort. Oh, this is a big one that we didn't cover. I'm glad this has come up in a question. A small amount of discomfort in the muscles or joints during or immediately after activity is common following performance of unfamiliar activities and hence does not necessarily mean joints are being further damaged. What do we think? Absolutely. This is absolutely true. So manage people's expectations. Say they might feel a little uncomfortable after a yoga practice. It doesn't mean the damage has been done. Actually, that's going to help them long term. There we are. So a couple of additional resources as we wrap up. This is a great online course by a guy called Greg Lehman called OA Optimism, specifically for knee or hip OA. I'm going to send you the link. I'm going to send you the link to the book that I've mentioned. Really cool. There's a couple of other resources here. Your homework is to write down 5 things that you'd like to take away from today and then discuss these points with someone else in your life. You'll receive a copy of the slideshow along with all the references. I know I've been talking a mile a minute. Here's my email, info@dr-yogi.com. There's a couple of very personal questions for people. I recommend you email me and I can try to point you in the right direction. So info@dr-yogi.com. And then I've just launched a really exciting community for yoga teachers. It's an education-based community, focuses on anatomy, physiology, and the business of yoga. The Embark tier is free. There are 4 fantastic courses that you can do in there at your own pace. I'm going to follow up with a link to that. I highly recommend you join the community, and it's a great way to get support from other teachers as well. So thank you all so much. God, I can talk, can't I?
Yeah, it's great. It's all great information, honestly. And I wish we had more time, but like Andrew said, we'll follow up with the slideshow. So anything that we missed in there, you'll see. You will receive a follow up email tomorrow afternoon with the full recording of this webinar, resources, all the stuff that was mentioned, emails, links, all of that stuff. And we're just thank you for joining us today. And thank you, Andrew, for hosting another great
Oh,
webinar.
it's been my pleasure. Thanks to everyone for being so engaged. Yeah, please follow up. There's definitely a couple of personal questions. I can definitely point you in the right direction with that if you want to get some guidance. Yeah, enjoy
Awesome.
enjoy absorbing all that information. It was a lot.
Yeah, it's a lot, but all great information. So, everybody have a great Monday and thank you for joining us
Yeah,
today.
thank you so much. Have a great day.